Good morning. We're so pleased that you took time this morning to join us. We'd like to welcome you to the American Cancer Society Virtual Lung Cancer Leadership Forum for the states of Ohio and West Virginia. My name is Deb Dillingham, and I'm the Senior Director for Cancer Control Strategic Partnerships in the states of Ohio and West Virginia. It's my pleasure to welcome you to today's event. We have a very full agenda, and we would love to start out with asking you to help us. We have a poll question that will be on your screen asking you to let us know where you're joining from today. We will have several polls throughout today's conference. We'd like you to just make your selection and then hit the submit button. And I'll give you just a moment to do that for us as we begin. Okay, if you would make your selection and hit submit, we'll move on. So we ask that if you've called in from a phone today, that you please enter your name and your organization in the Q&A so we have record of your attendance. All lines will be muted during this program, and we ask that questions be entered into the Q&A tab on your screen. Each presenter will be answering questions after their presentation. If we don't have time to answer your question during the Q&A, we'll work with the presenters to have your question answered post-event. Now, I have the pleasure of introducing Dr. Douglas Flora. Dr. Flora is a volunteer with the American Cancer Society and is currently serving on the area board for Ohio, Northern Kentucky, and West Virginia with the American Cancer Society. I turn the program over to you now, Dr. Flora.
Morning, everyone. Thanks for joining us on this bright morning. It's great to get this group of esteemed colleagues together, and I think it's not lost on me that I started my very first oncology patient as a medical oncologist when I was a new baby doc at the James, when the James was in its infancy. So it's fun to see Dr. Carbone on here and some of the other colleagues. When I was first starting out as a cancer person interested in fighting cancer, that was where it began. So it's a full circle for me this morning. So just by means of introduction, the reason I sit in front of you is hopefully compelling. As a cancer doctor, that's easy, but I'm also a cancer patient. And so as we embark on the discussions today, I'm one of those people that we're trying to save because my cancer was caught early. It was detected at a stage 2, and I've got a very good chance to be cured of my cancer. It should be cured. I'm about 4 years out. But after going through that experience, I found my whole paradigm shifted as a cancer doctor and as a leader here. I'm an executive medical director over a 5-hospital system cancer program. And after experiencing what it was like to be a patient, I became almost evangelical in my pursuit of better screening and early detection. And that's part of what led to me serving on this area board for ACS. We have seen unprecedented advances in survival over the course of the last, say, 5 or 7 years in cancer, largely led by improvements in therapeutics and surgery and radiation and screening, and mostly because of advances in lung cancer and melanoma. So this group, and I'm sure Dr. Carbone and others will speak to that, we are making incredible inroads as we've seen stage migration as the national conversation has moved towards screening, and USPSTF has finally adapted some guidelines there, but there's still work to be done. You'll see statistics today about where we fall short and where we're having successes. Where I sit, I'm glad to say that Kentucky is starting to get it. I work in a healthcare system right across the river from Cincinnati, and we're going to hit our 20,000th lung cancer screening CT this month. And we've seen 146% drop in 146% increase in the number of patients at stage 1 disease and a 70% drop in the number of patients with stage 4 disease. So we know that this works. Our internal data is going to be published here shortly, that you can do this even when you're not the James, even when you're in a community setting like many of us are. And so I'm encouraged to see leaders coming together to discuss how we can bend that curve together with better partnerships with groups like ACS, better communication, better cooperation with industry, and trying to find new models to reach the patients that we're still not meeting. Obviously, we'll hear a little bit today about the populations that are still underscreened, and it's deep. And we know that there's some financial implications in terms of whether or not you make more or less than $75,000 a year. There's a steep drop off and the ACS has presented that data. We've got to reach these other communities of color, elderly patients, disadvantaged patients, language barrier patients, and find better diversity and inclusion in terms of the people we're reaching, because we're really, really good. right now at reaching well-educated people in nice community settings where they've got lots of access to care. But 20 miles south of me, we're missing everyone in Appalachia. And so I think we'll hear some about that today. I will say another thing we probably are all cognizant of is the hit screening took with COVID. We'll talk about that today in detail as well. It's been well documented that there have been a major drop in our screening and prevention efforts across lung, colon, breast, cervix, and other places where we were previously making great inroads. We took a hit. And part of this team is to try and get us back on track. There are some big groups working on that with ACS and Stand Up to Cancer and Genentech with a big national push to return to screen, and Cancer Screen Week coming up here soon, and a lot of big programs going on at each of your institutions. So it's an exciting time to be in cancer medicine, because if we find them early, people like Dr. Carbone, myself, and others have better tools than we've ever had before with regards to better surgery, better radiation, more focused and targeted therapies for patients who've had resection, and then better adjuvant therapies. And so for those of you on the front lines who are helping in the advocacy efforts, who are helping in the education efforts, it is absolutely worth finding these patients. And I'm waiting myself to hear the most current statistics these guys will present. But the last numbers I read for lung cancer were that we were still around 6% or below in most regions for eligible patients screened. And we're not much better here. We're at 36 to 38% in Northern Kentucky. But that still means that 6 out of 10 patients that we might have saved, we didn't. And so we all as a team on this call have to figure out better ways to reach the patients that we're not reaching. So it's encouraging to me when we see industry cooperating, when we find these unique partnerships, and we're starting to see lots of teams that used to not work together trying to work together to find these cancer in their faintest footsteps. And for me, that's exciting as a cancer patient. And I applaud all of you guys that work on this. I'm deeply involved with the American Cancer Society, and I've chosen this as the place where I put my free hours, and I say that in quotes because none of us really have free hours anymore, because I believe in what you guys are doing. And I have come to this at 50 as a cancer doctor, that we are going to beat cancer by finding it in these faintest footsteps and not with drugs and stage 4 disease. And I love that trials are headed that direction. So I'll open this thing with a quote that I have shared with my team this week as we're trying to bridge new areas in Northern Kentucky here. This is a line on the power of collective hope, which I think is what drives all of us. I know at ACS, that's the fuel that you guys burn, and it is absolutely worth it. If what we do today saves one life in Columbus or West Virginia or Northern Kentucky, then our time was well spent. So as we embark on this, hope is like a road in the country. There was never a road, but when many people walk on it, the road comes into existence. And I feel like that's what you guys do. By advocating for us, by getting us tools, by finding new paths, you guys are building roads to get these patients to the doctor sooner and faster so that we can have a better chance at curing them and getting them back for their own family Thanksgivings, their own family Christmases. So I guess my charge to the panel as I leave this is to think about this not in terms of statistics, not in terms of programmatic gains. Individual patients that you find with stage 1 disease can be cured, stage 2 disease can be cured, stage 3 disease can be cured. And your job and our job together is to find a way to get more people in those stages so that those patients don't have to feel the terror and the devastation that many feel today in my clinic. So with that, I'll pass it back, and thank you, and looking forward to the proceedings, and I appreciate being asked to introduce.
Dr. Flora, thank you so much. We do appreciate you being with us, and we appreciate your great words. I'm going to ask our producer to back up one slide because I'd like to thank our sponsors today. We would like very much to thank the James of The Ohio State University, Summa Health, and the Ohio Area Health Education Center. Our program is also supported by the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalition. We are so grateful to our sponsors for making this program possible. And I'd like to share with you now, if you'd advance the slide, today's agenda. If you'd like to take a look at today's agenda, we'll begin with presentations by Dr. Ran Ely, Dr. David Carbone, and Dr. Brian Bowman, followed by an opportunity to ask questions. Then you'll have a chance to learn some best practices in lung cancer screening from partners in West Virginia and Ohio. Next, Kelly Durden will share some tools and resources available to you from the American Cancer Society to support lung cancer screening efforts. This presentation will be followed by an opportunity to ask questions of our presenter. You'll then have a chance to learn more about the work being done around lung cancer screening and tobacco control efforts into high-risk populations. Lastly, you'll learn more about an exciting program offered by the American Cancer Society called Get Screened before we conclude today's program. Next slide, please. Thank you. The Consortium for Health Education in Appalachia, Ohio, is approved as a provider of nursing continuing professional development by the Ohio Nurses Association and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. This course will provide 2 contact hours for nurses. You will receive a certificate for claiming your CEs after today's event. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that slides will be available after today's presentation, and this is being recorded. Now, it's time for our first poll. We would love to know, oh, we've already done that poll. I'm sorry, let me go on. We'll move on to introducing our first speaker. If you would advance the slide, please. Thank you so much. Our first speaker is Dr. Ran Ely. Dr. Ran Ely is the Charleston Area Medical Center Pulmonary Critical Care Fellowship Program Director and is the Associate Professor of WVU Charleston Division in Pulmonary and Critical Care. She holds degrees in biological sciences, chemistry, and psychology from Ohio University. She received her medical degree from The Ohio State University and pursued internal medicine pediatrics residency at Indiana University, where she served as chief resident. She joined the WVU faculty after completing fellowship in pulmonary critical care at the University of Kentucky in 2012. Dr. Ely has multiple research projects in the area of COVID-19, lung cancer, sepsis with pneumonia, and mechanical ventilation, supported by 2 grants. Her work has been presented and published nationally at the state level and locally. She serves as a reviewer for several journals, including Lung, Academic Medicine, and MedEd Portals publications. Her clinical interests include resident fellow education, lung cancer, interventional pulmonology, pulmonary hypertension, critical care, and ECMO. Thank you so much for joining us, Dr. Ely. We turn the podium over to you.
Thank you so much, Deb, for inviting me for this forum. I'm Dr. Ely. As Deb said, I'm part of this general vicinity. I did all of my training in Ohio, Kentucky, West Virginia is where I am now, as well as Indiana. I'm the lung cancer program screening, or the lung cancer screening program medical director, and the division chief for CAMC as well for pulmonary critical care medicine. Can you go to the title slide, please? Next slide. I'm going to talk about some research that we did here at our institution, Charleston Area Medical Center. That was funded by a grant from the American Cancer Society, and that's my only disclosure. Thank you. Next slide. Our objectives today, I'm going to review, just so you know a little bit about what we do here in Charleston, what our statistics are like for lung cancer, discuss how COVID operationally affected our lung cancer screening programs, and then talk about some of the research that we did with patient perceptions generally around lung cancer screening, as well as how COVID impacted our lung cancer screening program. That's actually a cancer of our beautiful picture of our cancer center here in Charleston, West Virginia. Next slide. So Charleston Area Medical Center, we're a community-based academic medical center. We have approximately 1,000 beds. We have the largest cancer center within West Virginia. Our patient population, we have about 180,000 patients here in Kanawha County, but our service area actually encompasses over 500,000. More than 35% of those patients are over the age of 55. We have an older population here in West Virginia, and so many of those patients are smokers as well, as you'll see. We have our lung cancer screening program started in 2014. All of our high-risk scans, those lung RAD4 cases, are reviewed by a multidisciplinary team with an auto referral to pulmonary in place if the patient does not have an established pulmonologist, to take that burden off of navigation from the primary care doctor that we know are all burdened in healthcare. This process really was designed on our multidisciplinary breast centers approaches to mammograms and has worked out well. Next slide. Our burden of disease in West Virginia, it's no secret that Kentucky and West Virginia usually compete for the patient population who has the highest amount of smoking in the country. And so currently West Virginia has 26% of their adults that smoke. Compared nationally, that's 14%. So quite a bit more of West Virginians smoke than those across the nation. We also have the most minors living within West Virginia. So we have about 17,000 minors in this state. That's more than the next two states combined, which are Kentucky, one of our neighbors, and then Wyoming has a large population of minors as well. So coal dust is a risk factor as well. You can see that our lung cancer incidence is 81 out of 100,000, whereas the US rate is 58 out of 100,000. And our lung cancer death rate is 79 out of 100,000, where the US rate is far lower. The distribution within West Virginia for lung cancer incidence is there on that map. We're in that dark orange area here in Charleston. So we serve central and southern West Virginia. Most patients, when they get diagnosed in West Virginia, are either regionally metastatic disease or distantly metastatic disease. So only a few people, that 21% that you see there, are diagnosed early, which have a better chance of curative stage lung cancer. Next slide, please. So what happened in the spring of 2020 affected us all in many ways, and that affected healthcare in many patients as well. So patients stopped going to their primary care doctors, whether it was sort of mandated because of shutdowns or fear of being exposed to COVID. Here at CAMC, we actually stopped elective testing during April for a 3-week period in April, but our staffing actually was pretty heavily reduced thereafter because of redeployment into the inpatient space. And so we had limited availability for outpatient testing for at least another month, but actually it's our staffing issues, much like across the country, are ongoing. Patients also had reduced follow-up visits during this time. So even if they had screening or a primary care doctor visit earlier than the pandemic, all their follow-up visits were sort of dropped as well. Next slide. So we took this opportunity actually to do a survey to assess patients' attitudes of why they got lung cancer screening. We had already been planning a survey like this, but took the opportunity to add some COVID questions in there as well. We sent the questionnaire 2 weeks after a low dose was completed, gave them a little incentive to complete the questionnaire and return it. We actually had a phenomenal return rate of 34%. Out of the 505 people that returned their surveys, 29 actually did not meet inclusion criteria. 16 of those were because they said they hadn't gotten results yet. And then 12 stated that they hadn't actually completed a low dose CT. So I'm not entirely sure what happened with those patients, if they just blanked it out of their memory completely. But there were a few people that did not meet inclusion criteria. Next slide, please. And so one of the questions that related to how COVID affected their lung cancer screening was, simply, was your lung cancer screening appointment delayed because of the COVID-19 pandemic? A very, very small percentage of patients, 7.1%, actually stated that cancer screening was delayed because of COVID. 4% didn't really know if it was delayed or not. Another question on the survey were follow-up recommendations affected by the COVID-19 pandemic. Only 2% of people actually stated that the COVID pandemic affected their follow-up. So if they had a high dose or a high risk scan, only 2% of people said, well, I couldn't get what I needed because of COVID. So a very small percent. Then we asked another question: why might not you follow the recommendations that were recommended by the lung cancer screening test that you had? There were a fair number of people, about 14%, that actually said that their finances had changed because of the COVID pandemic. So patients had either lost their employment or maybe lost their insurance. And there were approximately 10% of patients that were were afraid to get exposed to COVID-19 going out in public to a healthcare facility. Next slide. This is what reality looked like, though, for us. So this is our lung cancer volume since 2017. And you can see in the 3 years preceding COVID, our lung cancer numbers steadily increased with more and more adoption of screening. I'm not entirely sure what happened in Q1 of 2019, but there's a little dip there. But in general, our lung cancer screening numbers improved. The first quarter of 2020, that January, February, March period, people actually stopped going to their primary care doctor and getting orders for screening. You can see that our screening program actually had a pretty decent drop in the number of tests that we were doing. That second quarter in 2020 was when we stopped elective testing, and we had reduced staffing as well. And so you can see we even took a bigger hit in our numbers, which reduced pretty dramatically. We rebounded, though, in the latter half of 2020 with a recovery of these numbers. And actually, when you compare 2019 to 2020, our numbers for the total number of lung cancer screening tests that we did were exactly the same. You can see there might be an increase there in the third quarter of 2021, that there was a big uptick in the number of patients that we screened in the last 3 months. It'll be interesting to see what this last quarter of 2021 brings, to see if some of those patients that maybe had missed their appointment a year ago in that spring and summertime of last year now finally went to their PCP visit a year later, and now are starting to catch up on their screening. Next slide, please. We also looked at the percentage of high-risk scans. So these are our LUNGRAD4 patients. Those are the patients that have higher risk nodules, the ones that are larger and have features that are more concerning for cancer. As expected before COVID, in a cancer screening program that's been implemented, our percentage of patients that had high-risk scans seemed to be decreasing. COVID happened, and with our screening that has been reinstituted since then, our numbers, the percentage of patients that have high-risk scans seems to be increasing. Again, it'll be interesting to see what that last quarter of 21 brings, but it's intuitively, this makes a lot of sense. If people have delayed their cancer screening and that nodule may be increasing in that year, it's a possibility that if it's progressed to a more high-risk scan. Next slide, please. Oh, next slide. And those are just the trend lines as I spoke about. So the perceptions and what reality was, there was a really large disconnect. So very few patients reported that their screening was delayed because of COVID. Very few actually stated they considered COVID as a factor when getting their screening or follow-up scans. But the data shows otherwise. Our screening definitely declined during the COVID pandemic. And there's also a possible increased risk of high-risk scans during that post-pandemic period. Next slide. Our data is actually supported by several several studies that have been done at other institutions. I looked at a couple of studies. This one was done at the University of Cincinnati, looking at their screening programs from 2017 to 2020. You can see a big reduction in their lung cancer volume during the COVID pandemic on that left side. And they also reported a statistically significant increase in their referral for intervention post-COVID. So those patients that got screened after COVID had a higher number of people that needed intervention because their screen results were of higher risk. So they needed a biopsy or ongoing testing. Next slide. This is another study from Mass Gen. You can see on the left slide that their lung cancer screening volume decreased by 74%. It was very significant. It's the blue line on the bottom line there on that left-hand slide. And although it increased post-pandemic, it only reached about 70% of their prior volume. Their mix of lung cancer, the results, so whether it was low risk or high risk based on LRADS, they did completely recover their number of cases for LungRAD4, that high risk scan. And so, you know, if their absolute number recovered to where it was pre-pandemic, but their number of total lung cancer screening cases that they did during that time was still not recovered, that means their percentage of high risk scans was actually higher. Next slide. This is a study looking at trends across the country. So you can see across the country, some states saw similar trends where their lung cancer screening had reduced, while other states actually had increase in their screening. So to try to interpret this slide for you, because it's a little busy, this is a slide looking at 2019 volumes compared to 2020 volumes. And the percentage of patients in each state that got screened are the red bars. Their comparison number for 2020 during the pandemic are the blue dots in line. So if you're above that dotted line, you've actually, those states actually did more screening during COVID than they did pre-COVID in 2020 or 2019 rather. And so there were states that actually decreased as much as 50% in their lung cancer screening volume. About half the states actually did not change statistically significantly, at least. And then 19 states actually had an increase in their volume by more than 20%. As I stated before, here at CAMC, our lung cancer numbers actually our absolute numbers had maintained consistency during that time. This is looking at a percentage of patients that are eligible for lung cancer screening within each state. So this really suggests that health systems and local and state level cancer control effects played a role in lung cancer screening, but also stay-at-home orders for each state varied widely. And so that probably affected some of these screening numbers as well. Next slide. One last study we'll look at, there was a similar survey that was done at the Moffitt Cancer Center in Tampa, Florida, that they conducted during COVID. And 160 patients return a survey, and a similar percent to ours, about 10% stated that they had some concern about COVID during their lung cancer screening process. Only 8% reported that COVID actually prevented them from getting a low-dose CT scan. So again, there's clearly a disconnect between what patients' perceptions are and what actually happened during 2020. Next slide. So in conclusion, COVID, affected many parts of our lives and still does actually. It's not surprising that it affected lung cancer screening numbers as well. There may be an increase in number of patients that we're seeing now with higher risk scans because of the delay of screening that they got last year. Despite clear evidence that there are decreased numbers of screening during that time, patients really did not report a delay in their screening, which really demonstrates a disconnect and lack of awareness in the public about the importance of low-dose CT scanning. Very few patients were concerned about COVID exposure during the testing. And so there really needs to be an increased effort for lung cancer screening. As Dr. Flora stated, there's definitely work to be done with regard to lung cancer screening. And as you saw on a previous slide, about 6.5% of patients nationally that are eligible for lung cancer screening get screened. So we need to do a better job of trying to get the word out that the patients that are eligible need their screening test. Next slide. You don't know what you don't know. So it's important for, again, patients to understand what a lung cancer screening test is and to get screened. November being Lung Cancer Screening Awareness Month, I think all of us have that responsibility to promote lung cancer screening within our areas and as much as we can to our patients. Next slide. And with that, I am done. If you have any questions, please let me know.
Thank you so much, Dr. Ely. We certainly do appreciate it. We're going to hold questions until we've heard our other two panelists, if that's okay with you, Dr. Ely.
Sure.
Super. Thank you so much. We appreciate it. Next, we're going to have a poll question pop up on your screen again. You will see that we would love to know what sector you represent. So if you would just take a moment, please, to let us know what your sector is. We would very much appreciate it. Just make your selection and hit the submit button, and we'll give you just a moment to do that. All right. Our next speaker is Dr. David Carbone. Dr. Carbone is Professor of Internal Medicine, Director of the James Thoracic Oncology Center at the Ohio State University Medical Center, and he holds the Barbara J. Bonner Chair in Lung Research. His research interests, grant support, and publications have been focused on lung cancer. Recent research directions include development of molecular biomarkers to guide patient management and therapy. He has served over 200 peer-reviewed publications, books, and review articles, has served on several NCI grant review panels, including the Clinical Program Project Parent Committee, and has continuous NCI funding since early in his career. He's served on the Board of Scientific Counselors for the NCI and is currently chair of the Lung Biology Subcommittee for the Eastern Cooperative Oncology Group and past president of the International Association for the Study of Lung Cancer. Dr. Carbone, welcome this morning.
Well, thank you very much, Deb. I think those was a terrific introduction by Dr. Flora, and then a very comprehensive talk by Dr. Ely. But I would like to talk a little bit about the program at Ohio State. And I would like to start by saying that I'm a medical oncologist, and I'm exactly the person we're trying to keep patients away from by early detection. And that our program is actually run by Mike Wirt, who's actually on this call and hopefully will be available to answer questions. And let me just go ahead one slide. And then just one more click. Another one. So this was our volume during from 2018 to 2021. We actually closed down our screening program in the months you see in the middle of June 2020, and but since then our trend has been in a slowly increasing number of completed screens. Next slide, please. So this shows a cumulative annual number of screens since we started our program in 2013. And you can see that starting with 79 screens in 2013, we're projecting over 2,000 in 21. And on the right side of the screen, you can see the number of lung cancers diagnosed. In the in the red, the numbers diagnosed in their subsequent scans. And my internet is a little flaky. I apologize for that. I'm actually sitting in a hotel in New York City right now. So we've been detecting these lung cancers early with the screening program, and that's very encouraging. Next slide. So in addition to the screening program, Jasleen Panu, this is not my latest set of slides. I guess you didn't get the updated version. But these are data from Jasleen Panu, another pulmonologist in our program who is running a lung nodule clinic. And because of the really low screening rates of single-digit percentages, and the fact that not every patient is eligible for screening, a lot of our screens a lot of our detected lung cancer, unfortunately, is still in patients who have incidental nodules discovered on scans done for any reason. This was a study done by Jasleen of all CT scans that included the lung done at our institution. And you can see, this is a complicated slide, but it looks at those that had incidental pulmonary nodules that were detected and adequately followed up, not adequately followed up. And you can see in the different bars when it says not completed is the number of nodules that were not properly evaluated. And especially in abdominal and neck scans, close to 50% of all the incidentally detected nodules in our system were not adequately or not appropriately followed up, which represents a lost opportunity for these patients to be cured potentially. And so she has established a lung nodule clinic in collaboration with our lung cancer screening program to, in a regularized way, follow up on these pulmonary nodules. Next slide. So just in summary, there was a pause in our screening program during COVID, but those numbers are pretty much back to normal now. And the delayed diagnoses would likely result in a more advanced stage of diagnosis. But I think the real problem is exactly as what has been mentioned. That's the low awareness and screening rates for lung cancer in general. Single-digit fractions of eligible patients is inexcusable in today's world. And I think this is due to a slow adoption by family practice physicians. I recently, I went to a lecture by our head of general medicine at Ohio State, and they went through the whole hour talking about how they had prompts for reminding about colon and breast and prostate and ovarian screening, cervical screening, but they didn't mention in the entire talk, didn't mention lung cancer at all. And lung cancer screening rates are really not a component of hospital quality metrics in most systems. And there are regions of low access that has been mentioned. And we recently obtained a multi-million-dollar grant from Genentech to fund the operation of a mobile screening van specifically targeted to underserved areas in Appalachia and other underserved populations. And we're planning getting this operation on the road now. And this is run in collaboration with Electra Piscata and Chastity Washington, who are part of our cancer Center for Cancer Health Equity at Ohio State. And I think equally important, especially in an era of low CT screening and the fact that many lung cancers arise in people who don't meet eligibility criteria for CT screening, I think it's very important to make sure we follow up on incidentally detected nodules as established by Jasleen at our place. So that's just a high level overview of what's going on at OSU, and happy to answer questions in this section.
Thank you so much, Dr. Carbone. We do appreciate it. If it's okay with you, we're going to hold questions until after our next speaker and ask the panel's questions at one time. So thank you so much. We appreciate it. We're going to do another poll question right now. This poll question will ask you, you'll see it on your screen, what do you see as your biggest challenge to lung cancer screening? So if you would just take a moment and make your selection, this could be multiple choice. Please make your selections and hit submit. We'll give you a moment to do that. All right, hopefully you've had time to make your selections and submit your poll choices. We appreciate that so much. Our final speaker of the panel is Dr. Brian Bauman. Dr. Bauman was raised in the Akron area. He attended medical school at Case Western Reserve University in Cleveland. Following his residency and fellowship at the University of Michigan, he returned to Akron to practice at Summa Health System. He volunteers at Open M Clinic in Akron and spends his free time with his wife and his children. He specializes in pulmonary medicine and lung nodules with expertise in advanced bronchoscopy, EBUS, and navigational bronchoscopy. I present to you Dr. Bauman.
Well, thank you for having me. I'm happy to be here. This is really an area that I'm very passionate about. Now, I'll start off by saying that I am primarily a clinician. And so, there is some data included in our slides, which we're really using to work on our quality improvement of our lung cancer screening and pulmonary nodule program. I started our lung nodule program, I believe, in 2013, kind of with the onset of lung cancer screening. And we've really built a very successful pulmonary nodule program, primarily through really grassroots efforts. And, that last poll question that you put up was kind of interesting to me because I couldn't actually pick a good answer to that. I really think the biggest barrier to lung cancer screening is awareness more than anything else. And as a system and as a provider, I really strive to increase awareness about lung cancer screening and the benefits of it. So can we go to the next slide, please? So here are my objectives, and I'll talk a little bit in more general terms about lung cancer screening, a little bit about the impact of COVID-19 on lung cancer screening and lung cancer care, really the importance of the process for management and the management of incidental and also screening nodules. Also talk a little bit about lung cancer staging from a pulmonologist perspective, because we really have to think about staging as we diagnose lung nodules and lung cancer. And also talk about the benefits and really utmost importance of multidisciplinary care for lung nodules and lung cancer care. Next slide, please. So general statistics, most people in this audience probably know this, but lung cancer is the #1 cause of cancer-related death in the United States. It really represents a huge portion of cancer deaths, about 22%. And now it's the second most commonly diagnosed cancer behind breast cancer. It represents 13% of newly diagnosed cancers and kills more people than the next 5 cancers combined. Most lung cancer deaths are related to tobacco, but we all know that there's a significant number of people who also are diagnosed with lung cancer who have never smoked. And that's probably important for the stigma of lung cancer. Lung cancer was historically diagnosed late, and that's what leads to its high mortality rate. But really, screening is the first step in offering hope, because we're able to detect lung cancer at a much earlier stage. Next slide. So to go back to why we do lung cancer screening, this is a graph showing the improved mortality in patients who were screened in the National Lung Cancer Screening Trial, which was completed about 10 years ago. And hit the button one more time. So there's a 20% reduction in lung cancer specific mortality when we do lung cancer screening. And that's really what started lung cancer screening, and why, if you look at everybody's slide, most of their programs started in about 2013, which is when Medicare approved lung cancer screening. Next slide, please. Again. So in that study, I think we have to look at what happened. And first of all, in that study, the study group used a multidisciplinary group to deal with the findings of their lung cancer screening. And hit the button one more time. So if you look at this, there's a huge number of positive results. And that doesn't mean that there was lung cancer diagnosed. In fact, there's a very small absolute number of lung cancers diagnosed. But over 25% of the patients had some abnormality found on their lung cancer screening. And this is part of the reason we use a kind of pulmonary quarterback model to deal with these screening results. and also why all of our patients are navigated. So we find not only lung cancer, but we find other pulmonary conditions and sometimes other cancers or serious conditions that need dealt with, and primary care doctors oftentimes don't want to or have the knowledge or skill set to deal with these. Next slide, please. So there's been subsequent studies to the National Lung Cancer Screening Trial, and this is a large study that kind of corroborates the data from the National Lung Cancer Screening Trial called Nelson, which was done in the Netherlands. Next button. So there was a similar rate of cancers found in the screening and usual care group. Next slide, or next button. But the majority of cancers found in the screening arm were stage 1A, which is fantastic news. Next. There was actually a higher overall reduction in lung cancer mortality in this study. Next. And specifically in women, that reduction in mortality was even higher. And, you know, I use this information to help get women screened in our program. Next slide. So these are the guidelines for lung cancer screening. And this is actually an old slide with not the updated guidelines. I think we have more people talking about this, but I just wanted to, you know, highlight that there are new guidelines by the USPSFT, which have expanded the age range and reduced the amount of smoking required to get screening. And a lot of private insurers are already signed on to this, including our local SumoCare insurance company. Next slide. So when we talk about lung cancer screening, you have to, at least in a general way, understand what lung-RADS is. And that's how we score lung cancer screening CTs. And the ones that are really most important, these scores are based on the risk of lung cancer. And so the ones that are lung-RADS category 4, which people have talked about, are really the ones that we care about and deal with in an urgent way. That being said, there's a lot of patients who are either benign appearing or have a lung-RADS 3 that when they get their subsequent CT, there is cancer or something else concerning found. Next slide. So we at SUMA are a lung cancer screening center of excellence, is designated by the Lung Cancer Alliance, and these areas are what make us that. And the part that I really want to focus on is this referral process to a lung cancer multidisciplinary clinical team. Next slide. So these slides look very similar to the slides presented in the prior two presentations. And on the far left, this is just showing the number of lung cancer screenings that we've done annually. And actually, if you look at the last one for 2020, that is a projected volume, and we didn't meet that projection. So if you look at the center bar graph, we actually did see a slight decline in lung cancer screening in 2020, which was primarily due to COVID-19, but we've rebounded quite nicely and continue to grow. And in 2021, we've exceeded all years, and that's year to date, and this is only through September. So we've grown dramatically, and that I will give credit to our navigators who have really followed up directly with patients and referring providers, ordering providers to get those screenings done when they were missed. And kind of correlating with those lung nodule screening volumes, our lung nodule clinic visits have risen steadily as well. And I'll talk about kind of the structure of our lung nodule clinic a little bit more in the future. Although I also want to note the role of virtual visits now in our lung nodule program, and I'll talk about this a little bit more later as well. Next slide. So this is really why we do lung cancer screening. And this is, SUMA specific, our specific data. But if you look, the orange bar is our lung cancer screening patients in 2019. And you'll see that 64% of our patients in the lung cancer screening group were diagnosed at stage 1 with only 5% in stage 4. And if you compare that to the gray bar, only 27% were stage 1 at diagnosis, and 44% were in stage 4. So we really see this stage reversal when we do lung cancer screening. And then this pie chart on the side is looking at 2021. And the important fact about this is we see that similar breakdown of more early stage cancers in our lung cancer screening group. But we did see a significant decline in stage 1 disease. And I attribute that to our lack of or missing some screenings due to the COVID pandemic. Next slide, please. So, what I really think about when we see these patients is what I want referring providers to really understand. And also this is what I talk to patients about, and that, most lung cancers are not, or most lung nodules are not cancers. But the reason we care about lung nodules is we want to make sure they're not cancer. And that's because if we find lung cancer early, it's very curable. And we base, the risk of that nodule being cancer on a couple things. One is the patient risk factors, but also the nodule itself. I also talk about considering staging up front. So you have to understand and think about lung cancer staging up front before any further diagnostic testing or particularly invasive testing is completed. Next. So again, most lung cancers detected by CAT scan are not, most lung nodules detected by CAT scan are not cancer. Next. And in fact, we're tracking our navigational biopsy results. And over the last year, we got a new system, and I've been looking at those numbers. And about 10% of the lung nodules that we biopsy here, and these are considered high risk, growing, enlarging, PET positive, spiculated nodules. About 10% of those are granulomas in our population, which is very important in the future, potentially, about how we manage these cancers and what is the next invasive test that we may do for these patients. Next. I think as a physician or a provider that deals with lung nodules, we have to understand several things, and that's pre and post-test probabilities. So what is the likelihood of this nodule being cancer, and understand how the next result affects that probability. I think we have to understand overdiagnosis. So we don't want to hurt patients, and any screening test carries the idea about overdiagnosis, that we may find cancers or findings that never would have hurt a patient. And we have to be careful about how we deal with those findings. And also understand what a false negative is. So just because we did a biopsy, for example, or we had a PET scan with low FDG avidity, it doesn't mean that that's truly not cancer. And we're very careful to make sure we kind of cover our bases to not rely on potentially falsely negative tests. Next slide. So when we see a patient, what I've sort of fought against through the creation of our lung nodule program is thinking about all these things, thinking about staging, thinking about what is the most appropriate test before we put a patient through any potentially risky procedure. And what we were finding prior to the lung nodule program is that oftentimes primary doctors were doing biopsies, or they were referring to sort of the wrong doctor initially, and things were getting delayed. Patients were potentially getting hurt by the wrong sort of biopsy, or they needed multiple procedures to really get the information they needed before they got to the treating physician. So this image is just a high risk appearing nodule or mass, but if you notice, there's really bulky adenopathy in the middle of the screen. And this is the reason we review these patients and decide to potentially do a EBUS, for example, as the first next biopsy. Next slide. So understanding staging is important. And so oftentimes with nodules, we will use a PET scan up front to determine kind of what is the best appropriate biopsy site. And this isn't a talk on lung cancer staging. It's just to highlight really how important understanding lung cancer staging is as you evaluate lung nodules. Next slide. So there are a number of diagnostic methods we can use to diagnose lung cancer or evaluate a lung nodule. Watchful waiting is pretty rare, Sputum cytology is probably even less commonly used. Frequently, there are, repeat CT scans or PET. Then there's bronchoscopy, there's transthoracic needle aspiration, and finally surgical biopsies. And those go in order of least invasive to most invasive, but also go in order of most accurate. And so, this is actually an old slide, and I think our newer experience with navigational bronchoscopy has put it on even ground with transthoracic needle aspiration in terms of accuracy, although the risk of the procedure is probably actually lower. And when combined with EBUS, oftentimes provides a lot more staging information. Next slide. So as Dr. Carbone mentioned, we also have a large number of patients that are found incidentally, and these are very important. And what we found, we started a natural language software program to screen our ER, our emergency department CAT scans. And what we found is a huge number of patients had lung nodules. And so this is just at the onset of this program, but we had about 30 nodules a month found incidentally and then picked up by this natural language software program. About a third of those actually have what we consider actionable nodules, meaning they're bigger than 8 millimeters. So those patients need either a PET scan, a follow-up CT in the short term, like 3 months, or potentially biopsies. And so now what we do as a result of this is we actually, when we get these high risk considered actionable nodules, is we actually automate a referral to our lung nodule program through our lung nodule navigators and offer appointments in that program, or at minimum directly communicate with the primary care doctor so the appropriate follow-up is obtained. Next slide, please. So this is kind of the overview of our program, and it's a little bit of a busy slide, but what I want you to understand is that there are kind of different ways to enter our lung nodule clinic program. One is incidentally, and that includes through our montage, our natural language software recognition. So those are CAT scans that may have been missed, or nodules on CAT scan that may have been missed. We have a lot of direct referrals for these incidental nodules from hospitalized patients or from outpatients. And then the navigators become aware of these patients, sometimes through radiology directly, sometimes through hospital admissions, or through other referring providers. And our navigators are very accessible and very open, and our program physicians are very much aware of the navigators and their role and their ability to assist in helping to get these patients seen in a timely and appropriate manner. The other way that patients come in is through our lung cancer screening program, and 100% of our lung cancer screening patients are navigated. So they're never kind of lost to follow-up, at least not without multiple phone calls and certified letters by our navigators. All of our LUNG-RADS4 patients are essentially offered a direct and expedited referral into our lung nodule clinic. In our lung nodule clinic, we actually see patients usually within 2 days of the incidental finding, if it's a high-risk finding, or if it's a LUNG-RADS4 patient. And we then communicate back to primary care doctors about this. If a primary care doctor wishes to continue the surveillance on their own, then we actually assist them, and the navigator kind of runs those cases by the medical director, myself, and also our multidisciplinary conference. So just as the National Lung Cancer Screening Trial did, we use a multidisciplinary conference to evaluate all LUNG-RADS4 findings and also any kind of high-risk finding. We also preemptively or prospectively evaluate those patients in our multidisciplinary conference who may require a biopsy. So we do not put patients through a high-risk, potentially high-risk procedure prior to deciding what is the best procedure in a multidisciplinary way, with involvement of our thoracic surgeons, our radiologists, and our pulmonologists. Next slide, please. So what are the keys to success for a successful lung nodule program? And most importantly, I think, is navigation. Having a team of really skilled and passionate lung navigators is highly important for a lung nodule program. You also need a champion. You need to have a physician who is respected and valued by the community, by the system, and by the referring providers. The champion needs to be really accessible to the navigator to answer any questions about what the meaning of a result may be, and how to deal with potentially high-risk patients, or with patients that are difficult to deal with sometimes, whether for social or personal reasons. That champion serves as a resource to the system and the community. Oftentimes, I get out into the community and give talks to spread awareness about lung cancer in a whole variety of settings. I think I have I'm kind of expected to be at a lot of community events, you know, like the Moose Club, and very small grassroots efforts like that. As a champion, you have to be supported by the administration, and there's a lot of information saying how that dealing with lung nodules and a successful lung nodule program is really beneficial to patients, but it's also beneficial to a hospital system to improve quality patient care and also financially. You have to have team-based care, and this includes, you know, multiple specialties, multiple providers, as well as a lot of ancillary support services, including smoking cessation. There's a strong reliance in this team-based care on our multidisciplinary conference. We also utilize APPs, or nurse practitioners, very much in our lung nodule program. There's a huge number of follow-up scans that need completed, and the patients really take time and want a lot of information, and those APPs are really getting very skilled at managing lung nodules and dealing closely with patients, and also relaying diagnostic test results. We've also started, and this is one benefit of the COVID program, we've started to really utilize virtual visits extensively. And the main ways we utilize those is for follow-up scans. So oftentimes the only test required is a follow-up CT scan, and virtual visits serve as an ideal platform to make sure that patients really do follow up and get the next appropriate test ordered without making them come in. And then some of those things about COVID, where patients are reluctant to go to the hospital or go to a doctor's visit, that's really negated by using virtual visits. The other way that we use virtual visits is for communication of biopsy results. And so we really work on limiting any delays in care, and that includes getting the results dealt with and getting those results to patients when we do lung biopsies, for example. And so we have a very beautiful system where we do procedures one week. About 6 days later, the results of those procedures are reviewed at our multidisciplinary conference. And the same day, there's kind of an entire morning of communicating those results directly to patients, and then arranging subsequent testing, including additional imaging, staging imaging, and appropriate referrals for treatment with either oncology, radiation oncology, or thoracic surgery. I mentioned that, and that includes, you know, our care coordination. So one of the things we really work on in our lung nodule program is getting patients the best first appointment. And what we dealt with initially before the onset of the lung nodule program was that patients got to the appropriate provider in a very circuitous route. And oftentimes they would be referred to oncology, they would be referred to thoracic surgery, to pulmonary, directly for biopsy. And oftentimes that was not the best person. And what that did was introduce delays in care. And so what we're really focusing on now is optimizing that pathway for patients so they get to the first provider quickest. And any testing that is required is done very quickly. And as I look at our last part of this is quality improvement, that's what we're really focusing on right now, is how do we reduce the time of each of those steps. So we're looking at the time it takes for a patient to get referred to each specialty, the time it takes to get the next appropriate test, whether it's a PET scan, pulmonary function test, et cetera. And we're looking at ways to reduce the time that it takes for each of those to happen. And the entire goal for this is so that, you know, patients with with cancer are diagnosed and treated very quickly. And that's in addition to keeping those, the stage as low as possible. And that's all I got, and I'm available for questions at the end. Thanks.
Perfect. Thank you, Dr. Bowman. We do appreciate your presentation very much. So thank you so much to our presenters, Dr. Ely, Dr. Carbone, and Dr. Bowman. We do have some questions in the Q&A, so I would love it if you could join us back on video and audio with our panelists. Thank you so much. Let me start with the first question. This one came in, Dr. Ely, when you were speaking, so I'm going to expect that this was directed to you. Do you think the uptick has anything to do with the new expanded guidelines?
For us here at CAMC, we have a really large percentage of patients that have Medicare and Medicaid. And as such, we have to follow CMS guidelines on what they'll pay. We have 85% of our patients are Medicare, Medicaid from an primary insurance standpoint. And so we have not elected to expand our coverage to the USPSTF recommendations of ages 50 to 80 with a lower PAC year history of 20 PAC years quite yet. We have expanded it in the last probably 4 months to patients that have private insurance, whose private insurance companies have covered that or are starting to cover it, but it's not a mandate by the government until I think it's 2023. And I think there will be more information on that later in today's webinar. But our uptick is not because of the expanded guideline recommendations that have been proposed in the past year, because we don't have that patient population that has insurance that will cover for it. So this is simply patients, I think, catching up on their missed screening opportunities from the last year due to the COVID pandemic.
Terrific. Thank you so much. We appreciate that. This one I'm going to direct to Dr. Bowman. Do you use lay or clinical nurse navigators?
Yeah, our nurse navigators are actually, we have 3 navigators, 2 of you for lung nodules, and then we have 2 additional lung cancer navigators, and they work really closely to coordinate care and hand off care as somebody may be diagnosed with lung cancer. But the lung nodule navigators, 2 of them are respiratory therapists. One primarily works in the emergency department side, and then the other one does inpatient and outpatient. And then we just added a nurse navigator also, who's an RN, and really helps with communication of results and that connection between the diagnosis of lung cancer and the treatment of it.
Great. Thank you so much. Dr. Carbone, you have your hand raised.
Yeah, I just wanted to emphasize really important points that Dr. Bauman made about the importance of systematizing the evaluation of these nodules. One of the concerns that primary care doctors have of CT screening is the high number of false positives, but the risk of that is really related to what you do with those findings. And inappropriate action on pulmonary nodules is a huge problem, both in causing unnecessary procedures in patients who end up not having cancer, but also delaying diagnosis and staging procedures. And his point of appropriate first follow-up just can't be overemphasized. That one scan he showed with mediastinal adenopathy, you'd be surprised how often that gets inappropriately referred to a percutaneous CT-guided biopsy. And then you have to go back and do another procedure to stage the mediastinum. And even worse, sometimes in that screening CT, you see a big liver mass. And that patient is referred to a pulmonologist or a CT-guided biopsy of the lung. And then but you actually have metastatic disease, and the initiation of therapy is dramatically delayed. So systematizing these evaluations is extremely important, and having people who do this for a living and navigate these patients as part of their job really improves patient care and reduces the potential complications that you can incur by doing inappropriate procedures. In addition, today, it's important to do genetic analysis of even resectable lung cancers, because there's now adjuvant immunotherapy and adjuvant targeted therapies that are FDA approved. And so getting adequate and appropriate biopsies sufficient for marker analysis is important. And that relates to knowledgeable people doing that first biopsy to prevent the need for additional biopsies.
Terrific. Thank you. Thank you so much. Dr. Carbone, Dr. Bowman, and Dr. Ely, we want to thank you so much for being a part of our program today, for sharing your expertise and your knowledge with us. We're incredibly grateful. We are going to move on to the next portion of our program, and we will see a poll question pop up. This poll question will ask us, do we understand the interval follow-up scan? If you would take just a moment and share your selection and hit submit, we would very much appreciate that. We will give you just a moment to make your selection. Okay. Thank you so much for participating. We want to give a big thank you to our panelists. We are grateful for your expertise. Thank you so much. We're going to move on now, and we'll hear a brief update from several partners on best practices in lung cancer screening across West Virginia and Ohio. First up, we have Lauren Hixenbaugh. Lauren is going to talk to us about the Lucas Mobile Lung Cancer Screening Program through the West Virginia University Cancer Institute. Lauren, welcome.
Hi, thanks for having me. We're going to talk a little bit about Lucas. That is the Mobile Lung Cancer Screening Unit from the WVU Cancer Institute. Next slide, please. So this is Lucas. I'll give you some fun facts here about Lucas in just a second, but Lucas is a unit that provides lung cancer screening to 42 counties throughout West Virginia. We focus mostly on the rural parts of West Virginia with limited to no access for lung cancer screening. And we provide lung cancer screening in a comfortable, convenient environment for women, men, transgender, and gender diverse people with private insurance, Medicaid, and Medicare. If you're familiar with Bonnie's bus, then you'll know a little bit about Lucas, as we based Lucas off of the success to complement the Bonnie Wells Wilson mobile mammography program. Next slide, please. So who is Lucas? So Lucas is an acronym for Lung Cancer Screening Unit. And Lucas is pretty unique as that we are the first in the nation that travels statewide without the need for facility-based power, making us truly mobile. We have a beautiful unit, as you can see the pictures in front of you. It's about 80,000 pounds, 60 feet long, which is about 15 feet longer than Bonnie's bus. Our scanner holds patients up to 660 pounds. Our accessibility gate allows folks in their wheelchairs up to about 2,000 pounds, and we can scan about 20 patients a day. We're currently at about 14 with our COVID restrictions. Next slide, please. So you see the map of the state here. As I said, we cover 42 counties in West Virginia. That is due to the West Virginia's Certificate of Need requirements. And again, we focus on the counties that didn't have an existing screening program, but the CON only limits the location of the unit, but it doesn't limit residents of West Virginia. So everyone is encouraged to travel and come to Lucas if they want to get screened on Lucas. Next slide, please. So you've heard a lot of people today talk about the eligibility. So I provided you with the 2013 guidelines and now the 2021 guidelines that have been expanded. So Medicare, Medicaid, and most private insurances cover the 2013 guidelines. And with this recent expansion, we're kind of waiting for that coverage to be throughout all insurances. But if you qualify under the expanded guidelines, you should just check your coverage of your insurance as it varies. But on Lucas, through donations and funding, we're able to cover the cost of folks that are under or uninsured who meet the eligibility guidelines. They won't be turned away. So we're really happy to be able to offer that service. Next slide, please. So this is just a brief overview of the process to get screened on Lucas. So typically I start with academic detailing or an orientation for the clinic. Then we get the order from the provider. We move to clinic staff and patients on Lucas. The clinic schedules everyone, and then we move to the screening day. Patients attend that event. Our staff works with the clinic to make sure that we have a full schedule for the day, and then patients get their screening. Screening takes less than 10 seconds, so appointments are pretty quick for folks. The results are mailed to the patient and they are faxed to the ordering provider. The screening results, and if the patients need follow-up, the patients are required to talk with their ordering provider. The provider can contact us, or the patient can contact us if they would like some patient navigation. And we work with them to identify locations that are close to the patient. And then if patients need more navigation to services, or they can return, of course, to annual screening if they don't, but they'll be supported by us and their oncology team throughout that process. Does anyone have any questions? I know that was really brief, but.
Fantastic, Lauren. Thank you so much. I'm monitoring the Q&A and I don't see any right now, but we are grateful for your presentation. Thank you very much. Next, we will hear from Angela Kalush. Angela Kalush is with the American Cancer Society, and she is working on a lung cancer screening project in Northeast Ohio through a grant through the National Football League. Welcome, Angela.
Hi, thank you. Good morning. I'm going to provide a brief overview of our NFL lung cancer screening and tobacco cessation project. Next slide, please. So this is a 2-year American Cancer Society project funded through the NFL and Crucial Catch. We were awarded in October of 2019. The primary awardee was Northeast Ohio Neighborhood Health Services, an FQHC here in Cleveland, also known as Neon Health Center. And as part of this project, we were asked to collaborate with a hospital system to help guide and build this project for lung cancer screening referrals. So we're lucky to be working with the Cleveland Clinic. And just to provide a snapshot of who comprises this team, from the Neon side, we're working with health center directors, the IT department, the appointment center, providers, and the pharmacy department, as well as leadership and administration. And from the Cleveland Clinic side, we are working with the Taussig Cancer Center Community Outreach and Patient Navigation team, the Lung Institute, as well as leadership and administration. Early on, we set our quality improvement goal to develop and implement a lung cancer screening program, to create a sustainable referral process to our hospital partner, and to enhance smoking cessation classes that were already being offered at Neon Health Center. Next slide, please. So the beginning of this project was our planning phase. We had regularly scheduled team meetings with members from both systems. We worked on goal setting, we built our aim statement, and we spent some time process mapping our ideal state of the project. We focused on N.KY work to build our screening referral protocol from scratch, because before this project commenced, there was no lung cancer screening referral process at Neon, but the two systems have always worked closely on community initiatives and other types of cancer screenings. So we were able to make quick work of this planning phase. And this project was definitely impacted by COVID-19 as our health system partners had to navigate the new pandemic. We did lose a little bit of momentum, but we moved everything to a virtual format. We held our team meetings online. I will add that process mapping to do over Zoom is not impossible, but it's just difficult. And the tobacco cessation patient classes offered at Neon also moved to a Zoom format, which was a little bit of a challenge for the participants and the facilitators, but the Neon team did an excellent job to ensure that every patient had access to these meetings. In our implementation phase, we started off with Neon provider education webinars focused on our new lung cancer screening referral protocol. We highlighted the availability of the tobacco cessation classes at Neon as well. And when it became clear that our referral numbers were starting out slowly post-COVID, the Cleveland Clinic team solved this issue by shifting to a new scheduling process. The Taussig community outreach team were doing outreach calls to eligible Neon patients, inviting them to schedule their low-dose CT at Cleveland Clinic and helping to navigate the appointment process for them. And this really helps us to get the ball rolling with our referral numbers. Shortly after that, provider referral numbers did start coming in as well. And it may be difficult to read this, but I just wanted to show this is our ideal state process map for the NEON side of the referral protocol. So each system worked on their respective maps, and then we had a joint meeting where we tied everything together to ensure that it flowed well and it was feasible for both sides. Next, please. So the current status of our project, the TOSIG Community Outreach Team's new referral process is really helping us make headway on our screening goal. We are gaining momentum this year after COVID-19 slowed down our project last year. We have created co-branded materials for patient scheduling, which I will share here in a moment. NEON has held several cohorts of the 8-week tobacco cessation classes this year. The director of pharmacy has really done a terrific job in keeping patients engaged with this new virtual format. And we have had the opportunity to share our barriers and best practices with other NFL project sites nationwide through the ACS NFL lung cancer screening and tobacco cessation echo calls. This allows us to get feedback from a panel of experts. It connects us with other sites to learn from their wins and setbacks in their projects as well. And this project was supposed to end last month, so we're very grateful for a no-cost extension until April of next year due to COVID-19. As far as continuation and sustainability, like I mentioned, these two health systems have always worked really well together. This project just allowed a new avenue of collaboration for a screening that was not previously focused on. It's allowed me to learn so much from them. It's allowed them to learn from each other. And it's been a true joy to work with this team. I'm really excited for the next 6 months of our project to see what we can accomplish. We definitely have our checklist ready to go. Next, please. And as I mentioned, this is a co-branded postcard that has been mailed to eligible NEON patients to invite them to schedule their low-dose CT at Cleveland Clinic. It spells out why the patient is eligible, what to expect from their appointment, what to expect from the screening, and the TOSIG cancer team's information if they have any questions. And that's it for me. Thank you so much for allowing me to share today.
Angela, thank you so much for sharing. We do appreciate it very much. Our next community program we'll hear about is through the lung cancer screening work done at Cabin Creek Clinic of the Charleston Area Medical Health Center. Thank you so much for joining us today, Chaffee Tomarello. I'll turn it over to you.
Have our first slide. Thank you so much for coming and paying attention. Yeah, there we go. So I just want to explain a little bit about the key players to this lung cancer screening FQHC and screening facility partnership. We had CAMC, which is a large hospital system in West Virginia, as you already heard about from Dr. Ely. Cabin Creek is an FQHC with 5 sites. If you're not familiar with the acronym FQHC, it's primary care, typically for the underserved populations. So our 2 facilities got an ECS grant together from that sourced from the Bristol Myers Squibb Foundation to help implement and streamline a lung cancer screening process in this part of West Virginia that has very high lung cancer, both morbidity and mortality. If we could have the next slide, we're going to talk about some lessons learned from this project. Our number one takeaway, and this is probably true of most projects most of us work on, is that communication is really key. As we have our quote from Anthony Starr, collaboration is the best way to work. It's the only way to work, really. And that was certainly seen in this project. Can we have our next slide? Thanks. Okay, so just a little bit about how we started. After we were approached by ACS, we had a meeting with all the stakeholders, including an initial meeting with Charleston Area Medical Center. They had already developed a really comprehensive flow sheet. It clearly had their process well thought out, but our FQHC is kind of small. One person there wears many hats. And so we were really grateful for how the American Cancer Society helped explain the players, made introductions. We already had this very high level of confidence and trust in CAMC patient care, but figuring out how we were going to do this project was kind of a challenge. So there was a temptation to make it provider-led. So at our facilities, the providers are very aware, very up on the medical literature, very engaged. However, most patients are sick. They're dealing with a lot of serious health conditions. And so the way we decided to approach this was to try to have staff take some of the more difficult aspects of navigating lung cancer screening off the plate of the providers. And CAMC really helped with that. For instance, if patients didn't have a pulmonologist, there was an auto referral option. If they had a scan that was concerning, for us personally at our FQHC, workflow was a much bigger concern or issue than provider education or buy-in. So as we were starting, there was this temptation to be really ambitious because we all see the need. I've lost multiple family members myself from lung cancer. And so there's this temptation to want to take everything on, and then you kind of get overwhelmed or burned out. So for us in our facility, it was more effective to start slowly. So we started with a few test patients from one site on one type of insurance. Much of the rollout was staff-led because, like I mentioned, our providers were really on board. So then we started having regular meetings with CAMC with specific cases, and we would follow up to do troubleshooting. For instance, if there was an issue with the insurance or with the flow of paperwork. And that's one reason why it was so important to involve frontline staff. We would meet with CAMC and figure out how the orders were coming into them, what information was missing, what was showing up in the wrong place. And then we would respectively go back to our administrations and make recommendations or describe the problems and let them help us figure out how to solve it maybe. So then we expanded to increasing more insurances, then more sites. We did some training about criteria or pack your history for the staff with sort of a brush up for the providers. At that point, we turned on the prompt in our MAR, Athena, to generate the prompts for the MAs to screen and the providers to refer once we were ready. So as we moved through time with this, we were so glad to have that close collaboration with CAMC and ACS because we had more unexpected issues. For instance, LungRads 3 has typically a 6-month CT. Is that diagnostic or screening? Well, the clinician answer and the insurance answer don't always necessarily coincide. So we had to get a whole new protocol to make sure that the patient wasn't billed for a diagnostic scan. So those were issues that were found by our frontline staff, but really couldn't have been resolved without administration, help with the MAR, help with the providers to sort of put their heads together and try to figure out solutions. So we found that it was really super important to minimize the insurance frustration to the providers because they're already so busy, they're already so overworked in primary care. If they have to spend a half an hour on a phone call with an insurance company, a lot of times that really can sort of make them take away from other more important patient care maybe, and also at the same time can kind of demotivate them to be full participants in this process. So if we go to our next slide, please. So Lurian Jeffries, who I think is on the call today, did much of the day-to-day management for this project for Cabin Creek. And at the invitation of CAMC, she and I went to the lung nodule multidisciplinary team that Dr. Ely described. And I have to say, this is just one of the most affirming experiences I've ever had in healthcare because just sitting through one meeting of that panel, we could see the detail and the care that CAMC put into the recommendation and decisions for each patient. They knew things like what their transportation was, what other health issues they were facing, what other health issues their family members were facing, and just treated it all with such care and respect. I feel like that really helped us know our partner better, if that makes sense, and gave us even more confidence. We could then take that information back to our providers and staff and our administration and not only tell them about the care our mutual patients were receiving, but it helped us kind of communicate with the patient and tell them what to expect, what the process would be like. I feel like fear and stigma is such a big concern When we talk about lung cancer screening, people are so easily scared off. So having that increased knowledge, the better communication, really, as our quote says, help determine the size of our result. So none of the stakeholders, I feel like, in this project could have identified and solved these problems in isolation. So because of that collaboration, we really could give better care to the patients. So if we could move on to our final slide. I just like to, yeah, sorry, maybe I didn't move on soon enough. Okay, kind of already summed that up. But implementation will fail without frontline staff engagement. Okay, now if we could move to our final slide. Yeah, so thanks for your attention. We'll let our chairperson decide if and how to proceed with questions.
Jackie, thank you so much. We don't have any in the Q&A right now, but we do appreciate your fantastic presentation, and thank you for being with us. I want to thank all of our presentations for our community projects, Lauren, Angela, and Chaffee. We've been incredibly grateful to hear and learn about the projects that are being done to impact lung cancer. So thank the three of you very much for your presentations. Next, I'm going to move on. We're going to hear from Kelly Durden. Kelly Durden is the Director of Clinical Trials Roundtable Prevention and Early Detection and Director of Lung Cancer Initiatives with the American Cancer Society. Kelly, welcome.
Hey, thank you so much for having me. So I want to thank you all so much for the opportunity to be here. I've been asked to be pretty quick, so I'm going to skip a couple of sections. I do want to say I am deeply humbled to be part of this session and just this process. I am not a clinician, and there are so many amazing presentations that I've heard today. In my work at ACS, I do manage several of our lung cancer projects, including the NFL project that Angela referenced, and I've been involved with the BMSF that we just heard. I also want to say I'm really passionate about this work. I lost my dad in 2011 to small cell lung cancer. He was 51 years old. I wish every day that he would have been able to walk me down the aisle or meet my son. So this is not only professional to me, this is very personal. You can skip ahead now to about, the next slide. Thank you. So I've been asked to talk a little bit about the burden of lung cancer, the screening guidelines and recommendations, a little bit about uptake, and then I'll conclude with a synopsis of ACS resources. Next slide, please. So I just want to start by saying this is really an optimistic time for lung cancer. As many of you know, for many years, we did fight a losing battle in our efforts to prevent lung cancer, especially for individuals who smoke or who have formerly smoked. And I want to just pause right there. Thank you so much. You can keep that slide up and just notice that I didn't use the word smoker or non-smoker. Those words, it's really important to use person first language. So yes, that's exactly the slide that I wanted. Thank you. So we've really entered a new era in the control of lung cancer with both the advent of new therapies as well as with annual screening, which we all know is associated with the reduction in lung cancer death. Next slide. And there really has been progress. You'll see on this slide since 1990, there has been a 54% decrease in lung cancer deaths in men. And in women, we've seen a 30% decrease in lung cancer deaths since 2002. Next slide, please. But there are challenges and many opportunities that still remain. You can skip ahead 2 slides. Okay, I'll skip this. I think we talked about it a little bit. I'm looking at the clock. Okay, I think this is really worth repeating that nearly 1 in 4 cancer deaths are from lung cancer. And presently, according to our own cancer facts and figures, only 17% of lung cancer cases are diagnosed at a localized stage. Next slide, please. So in other words, we know lung cancer is still the #1 lung cancer killer. Again, worth repeating, it kills more people every year than colon, breast, and prostate combined. Next slide, please. And as noted, while cigarette smoking does remain to be the chief reason for lung cancer deaths, it is not the only risk factor. There are additional risk factors like secondhand smoke, radon, and occupational exposures. I do want to reiterate, though, that while smoking is that #1 risk factor, anybody can develop lung cancer. So we're going to transition to talk a little bit about guidelines and recommendations, which we have heard a little bit already. Next slide. So this is a really, really busy slide. I just want to note that there's been a lot of work that has happened in the past 3 decades related to lung cancer screening. You'll see in the far left, in 1992, when I was 12 years old, LCAP launched, or the Early Lung Cancer Action Program. That screened about 1,000 high-risk asymptomatic participants and found in that study that about 80% of lung cancer diagnoses were of clinical stage 1. you'll see from 1992 to 2021, there has been so much work in lung cancer screening, which really brings us to the present day, where we've talked about the new task force recommendation statement, along with the AAFP earlier this year issuing a clinical guidance statement. Next slide, please. We know right now that low dose CT is currently the only screening test recommended for the early detection of lung cancer. Next slide, please. And I think we can skip this because we've talked about it quite a bit already, and I will focus on this slide. Again, I think the biggest takeaway that we haven't really talked about yet is just how the new recommendation more than doubles the US lung cancer screening eligible population from about 15 million individuals. It was previously about 6.5 million. And in addition, that's projected to include more women and more Black Americans. There's a lot of data that shows Black Americans and women tend to smoke less cigarettes than their white men counterparts. There's also some data to show that Black Americans have a higher risk of lung cancer than white people. So these changes could translate to more Black Americans and more females now being eligible for lung cancer screening. And at the bottom, I do have the pack your calculator. I know we know this already, but it is sort of a complex thing from time to time. Next slide, please. So how do the task force guidelines compare to some of the other guidelines from organizations? And this slide's pretty busy, but it does show not comprehensively every single medical society's guidelines, but it does show the different guidelines of some organizations. At the American Cancer Society, our guidelines are currently being evaluated. In the interim, we are recommending following the guideline from the task force, CHEST, or the AAFP. I also want to note that our guidelines are to be released either by the end of this year or sometime in 2022. And that guideline development is being led by Dr. Robert Smith, who I'm sure was the #1 choice for this call, but you got me, and so I'm sort of like the D list, I suppose. Really another important thing to note about this slide at the bottom is just the AAFP. In March 2021, the AAFP issued guidance agreeing with the new task force recommendation, and this marks the first time that they have ever recommended lung cancer screening. Prior statements for them were centered on not having enough data to recommend for or against lung cancer screening. The main difference from these organizations right now, with the exception of CMS, is the stopping age, and that varies from 80 to not really having a stopping age, as NCCN says. I do want to talk real quickly about CMS and Medicare because, as you'll see, they haven't changed yet, and their protocol is a little different. They use what's called a national coverage determination, or an NCD, and that's done through an evidence-based protocol with opportunities for public input. The last NCD from Medicare was issued in 2015. Several organizations, including GO2, and ACR, successfully urged CMS to reconsider, and earlier this year they did have public input. So Medicare right now is continuing to cover at the 55 initiation age and 30-pack history. Medicare, as every clinician knows on this call, also requires a shared decision-making visit. The new NCD from Medicare is expected to be announced in February of 2022. Okay, next slide. So I won't talk about this, but I do have the links if the slides will be sent out to NLST, Nelson, and Mild. Dr. Bauman already talked about these, definitely Nelson in his earlier presentation. Next slide, please. We've also talked about this, so we can skip that, and we'll go to the next slide, which talks about the biggest question that we've received, which is around coverage. So we have talked about this a little bit, but I do want to say again, for private insurance under ACA, health plans are not required to cover until the year of the date and or begins on or after. So it's a little confusing, right? There are health plans that are already covering it, as we heard from Dr. Bauman and others, but they don't have to until January of 2023. We talked a little bit about Medicare already, so I'll skip that. And I will say with Medicaid, it really varies between traditional Medicaid or expansion. In Ohio, obviously, Medicaid has been expanded, so lung cancer screening is covered under the ACA. But for the 12 states that have not expanded Medicaid, they don't have to. It's not a mandated service. And I believe there's still about 8 that do not cover. Okay, I don't know if I'm out of time right now, Deb or Shauna. I'm looking at the clock and I think you said 10:40. Do you want me to continue or skip ahead? Just let me know.
Kelly, we'd love for you to continue. We'll keep moving. Thank you.
Okay, just want to make sure. Okay, so we're going to go ahead to lung cancer screening rates and uptake. You can go to the next slide, and I think I can skip this because this was talked about already. You can go to the next slide. Okay, so state lung cancer screening rates are highly variable. From an individual state perspective, it looks a lot different. There are some states like Massachusetts that are nearly about 20%, and then there are other states that are about 1%. So next slide, where we're going to talk a little bit some of the reasons for low uptake. You can click 3 times. I should have taken out the animation. But our good friend, Dr. Lisa Carter-Harris from MSK, she outlined in this publication that the reasons for low uptake are multifactorial. They are patient level, provider level, and system level. You can go ahead. Next slide. Lung cancer screening is complex when it's compared to different cancer screenings. It does not rely solely on age. PAC history is hard to calculate for a patient. It may be hard for a system to track without investing in additional money. And, you know, it's also just with Medicare, there's the mandated shared decision-making. And I think cross-cutting is the stigma that's associated with lung cancer screening. Next slide, please. So one of the biggest differences between lung cancer screening and other cancer screenings is the stigma. Because of the close link between smoking and lung cancer, many people with lung cancer are blamed and or blame themselves for their disease. So what is lung cancer stigma? Next slide, please. So according to the National Lung Cancer Roundtable and the Initiative to End Lung Cancer, you'll find a working definition of lung cancer stigma. Due to time, I won't go ahead and read that, but I will say that lung cancer stigma ultimately impedes progress in lung cancer control. Next slide, please. And there are some real consequences attributed to stigma. Individuals who have formerly smoked or currently smoke have reported feeling denial, self-blame, fear of stigma from their clinicians, fear of stigma and anger from their loved ones or others. And at the bottom, you'll see I have a few just publications that even in them, in some cases, you know, they're blaming the individual for their cancer. Some research shows that individuals sometimes delay getting treatment because of the stigma associated. And another study has found the fear or knowledge avoidance to be one of the many reasons for opting out of lung cancer screening. Next slide, please. I'm going to move, I think right now, yep, we can go to the next slide. Okay, thank you. So first and foremost, in terms of the synopsis of ACS current resources, I want to just say that the ACS Cancer Control Strategic Partnership Managers, I still cannot say that without reading it, are one of the best resources that ACS offers. These brilliant individuals have led today's webinar. We've heard about the great work that Angela talked about with the Lung Change Project. We've heard about the great work in Cabin Creek in West Virginia. And a lot of this work is really attributed to not only the amazing systems, but to our field staff. So thank you to them. Also, you've heard me mention the National Lung Cancer Roundtable a few times. This was established in 2017. It is an ACS-led national coalition of public, private, and voluntary organizations dedicated to reducing the incidence and mortality from lung cancer. On this slide, I've included several resources from the National Lung Cancer Roundtable, including the Resource Center, our virtual meeting in December 6th and 7th. We invite you all to join, a webinar series. And then from ACS, we also have several patient and clinician-friendly materials with more resources coming from ACS later this year. I think that's all the time I have, and thank you all so much.
Kelly, thank you so much. We do appreciate all that you've shared this morning. Terrific information. You're going to see another poll question pop up on your screen. If you would, please let us know, does your EMR or EHR capture PAC year history? If you could take just a moment and make your selection, we would very much appreciate getting your information. That would be terrific. All right, hopefully you've had a moment to make your selection. We appreciate that very much. We're going to move on to our next speaker. We have two presentations yet for you. They both deal with audiences that are working with lung cancer screening in their own way. I'm going to introduce you now to Julia Applegate. Julia Applegate is with Equitas Health Institute, and she's here to talk with us about the LGBTQ+ population and lung cancer screening. Welcome, Julia.
Thanks so much for having me. So I'm really happy to be here today. I use she pronouns. I direct the Equitas Health Institute. We're located in Columbus, Ohio, but serve the state and larger region. I've learned a lot from being part of the audience today. I have lost 2 people in my life to lung cancer, neither of whom were smokers. And I had no idea there was such a thing as a preventive screening for lung cancer. So I'm so happy to have learned that. So I want to talk about the LGBTQ plus community, and I will also do this fairly quickly. But in our population, and I consider I am part of this community, I identify as a lesbian and a queer person, we are much more likely to smoke and use all kinds of tobacco products. So when thinking about populations that are disproportionately at risk for use of tobacco products, which we know contributes to lung cancer, our population needs to be considered. We smoke more. When we smoke, we're more likely to smoke cigarettes, we're using ends, and we're smoking little cigars more than other populations. Next slide. We're more likely, when we think about within our LGBTQ plus community, because it's very important not to fail to recognize that there are distinct differences across the letters of the LGBTQ plus and also within those letters. Thinking about gay and bisexual men, they smoke at higher rates than heterosexual men. There's a correlation between smoking and HIV, that many people who have HIV also smoke, and that contributes to higher rates of other kinds of cancers as well. Bisexual men are more likely to use ENDS products. Lesbian and bisexual women smoke at much higher rates than their heterosexual and cisgender counterparts. Bisexual women smoke at rates 2.5 times higher than straight women. And the trans community uses tobacco products at the highest rates of all LGBTQ plus individuals. So I was really happy to hear another presenter mention the trans and gender nonconforming community in doing those screenings. We can move on. Our youth are more likely to use tobacco. So within the LGBTQ plus community, it's not just adults who are using tobacco. Our population is smoking at rates ranging from 2 to 4 times higher than their straight counterparts. So the lesbian, gay, and bisexual community, they're smoking at rates 2 to 3 times higher than straight individuals who are young. In our trans population, they're smoking at rates 3.5 to 4 times higher than straight youth. We see higher use of ENDS products and smokeless tobacco than in our heterosexual or cisgender young folks. Next slide, please. When you think about the intersections within our community, we see smoking at higher rates in our Black LGBTQ plus populations. So they're smoking at rates 3 times higher than the rest of the Black community. Our Latinx and Asian LGBTQ plus individuals are also smoking at higher rates than white LGBTQ plus folks. We see elevated rates of hookah and little cigar usage in these populations. And LGBTQ plus individuals are more likely to be living with mental health challenges. And we know that people who have mental illness or mental health challenges are more likely to smoke. So we see elevated lifetime smoking rates among our LGBTQ plus individuals who have mental health challenges. Why are we more likely to use tobacco? There are many reasons. One is historically we've had to gather in bars and nightclubs because these were the only safe places to be. Historically, those are spaces where people smoke. Due to changes in laws, which are awesome, that smoking is often not allowed in bars and nightclubs and restaurants anymore. That's less of an issue than it was in the 90s and 2000s and prior to that. But these have been safe places for us to gather. There has been targeted marketing specifically to our population. SCUM stands for Subculture Urban Marketing, and that is a campaign that was started in 1995 by R.J. Reynolds that was explicitly designed to target gay men and people who were experiencing homelessness. So you see here a slide that is it's for me. It's for our population with the rainbow, like, hey, let's smoke. So targeted campaigns. And then LGBTQ plus individuals experience minority stress. We know that when people are experiencing stress, that tobacco can be a stress reliever. It's an unhealthy choice to relieve stress, but it's a common thing that folks who are experiencing minority stress turn to when they have that stress. Next slide. So when you think about doing campaigns with our population, whether that's a lung screening campaign or a smoking cessation campaign, it's extremely important to make sure that those efforts are community oriented and that they are affirming, and that we can see ourselves in those campaigns. So there are lots of things you can do to make sure that LGBTQ plus folks see themselves in your outreach efforts, but specifically targeting our population in an affirming way goes a long way towards reducing the disparities, and also, I would think, increasing uptake of screening. Next slide. And so you can make your programs or your efforts more affirming by being structurally competent. Don't have much time to go into that, but you can do that with rainbows and pronouns and making sure you're using gender inclusive language. And so just that's kind of what I wanted to share today. I'm happy to answer any questions afterwards or, in the future. But thank you so much for having me.
Julia, thank you so much for being with us. We do appreciate your presentation today.
Thank you.
Our next speaker with us is David Ellsworth, and David is the Health Policy Specialist, Principal Investigator from the Ohio State University's Nysonger Center, and lead on Tobacco-Free Ohio Alliance's health equity work, and he'll talk with us about health disparities among adults with disabilities. Welcome, David.
Thank you, everyone. So today I'm going to be talking about health behaviors and cancer screening among people with disabilities in the state of Ohio. Next slide. So 1 in 4 adults in Ohio have some form of disability. When you think about people with disability as a population, this is actually America's largest minority group. In Appalachia, the rate is actually much higher. It's closer to 1 in 3 individuals. So it's really important that we don't overlook the health needs of this population. People with disabilities have trouble getting health care for many reasons. Oftentimes, it can be difficulty scheduling an appointment. Lack of accommodations, and to kind of provide an anecdote, Dr. Lisa Iazzoni is a Harvard medical professional. She is also disabled. She writes about her experiences being a disabled doctor frequently. And one of her examples was when she was scheduling a mammography appointment and asked if it would be accessible to her, only to realize, in her words, that the accommodation was in the form of 2 sturdy gentlemen whose job it was to pick her up out of her wheelchair and position her against the mammography machine, which is obviously not best practice. But these experiences are fairly common among people with disabilities. So it's important to have appropriate accommodations that can assist with screening. There's also a general lack of training on how to interact with people with disabilities among physicians. Sometimes there's the inaccurate assumption that people with disabilities are served by different doctors or go to different screening facilities, and that's not the case. And then finally, there are some inaccurate assumptions about quality of life and health behavior among people with disabilities. And unfortunately, sometimes this results in people not being asked if they would like to quit smoking, assuming that the disability is what they are there to treat. So people with disabilities often face challenges accessing cancer screening as well. Next slide, please. People with disabilities have some health behaviors that make them more likely to experience certain forms of cancer. Chiefly, they are much more likely than people with disabilities to be current smokers. In the state of Ohio, it's actually nearly double the rate of smoking among this population. And actually that holds true for the regions that are represented on this call. So it's really important to acknowledge that. People with disabilities are also much more likely to be obese and have experienced some form of cancer. Next slide, please. People with disabilities typically have lower cancer screening rates. This is true for Pap tests and mammographies. but not necessarily true for colorectal cancer screening, where it actually depends on the disability type. So people with disabilities are not one big homogeneous group. It really does matter, what your lived experience is, and that affects your likelihood to engage in screening. But we obviously know that cancer that is found later is harder to treat. I was not able to find good, reliable data on the amount of lung cancer screening for people with disabilities, but I do believe that these other forms of screening hold true. Next slide, please. So there are some very basic actions that you can take to ensure that people with disabilities are accommodated. First of all, recognizing that the existence of services does not guarantee that it's usable, which was why I was so grateful to learn about the Lucas program that we talked about earlier, where that mobile facility seemed like it was very accessible. Asking about what accommodations a person needs during scheduling or before the appointment can go a long way to ensuring that people with disabilities can be served. Scheduling additional time as needed, and avoid making assumptions. Unfortunately, people tend to assume that they want the disability treated rather than some of the health behaviors or other conditions. Use plain language wherever possible in communicating, written or orally. And then finally, there's an ADA checklist that you can use for clinical spaces that will help you improve the accessibility of your clinic in just a couple basic steps. That's all I have. Thank you.
Thank you so much, David. We appreciate it. David and Julia both, thank you so much for sharing your information. It's contributed tremendously to today's conference, so thank you. As we wrap up today, we want to share with you a great program the American Cancer Society has launched called Get Screened. We do hope that you enjoy this quick commercial message, and we'll return with wrap-up details right after it.
No audio.
We'll ask our producers to address the audio issue for us, please. Let me ask our producer if you'd like to try that again, or if we are moving on.
Give me just 1 second to try to reshare and get that audio to work.
Terrific. Thank you, Susan. While we're waiting for that, actually, let me give you just a little bit of information. We do have more virtual forums coming up next year. We'll be setting the stage for health equity in all cancer prevention, early detection, treatment, and survivorship issues. So please keep an eye out for additional information for our forums in 2022. Right after this session, you'll be asked to complete a post-event survey. Completion of the survey is required to receive continuing education credits, and you'll also receive the post-event email with the recording of the session and the survey link. So let's try this one more time. Thank you, Susan.
My father was a military man, and he joined the Air Force when he was 18. And as with most military men at that time, smoking was considered cool. And he smoked the whole time he was in the military, about 20 years. He and my mother decided to quit, but his being a smoker was what led to, or what we believe led to, the lung cancer. So even though he had quit for a while, the damage had already been done. Dad was an avid fisherman. He loved to fish. He loved to fish, and that was after he retired from the military and from teaching. That's where you could find him, was out on the water somewhere with his fishing line. He loved his grandchildren and he loved his great-grandsons very, very much. They were his pride and joy. I think they even surpassed me after a while. When we lost him, it impacted our family greatly. That leadership, that guidance, that love was gone, and it hurt. It hurt bad. When I look back at when Dad was diagnosed and we realized how little time he had, there was a time that I wished I would have given anything to have had him screened earlier. It may have given him months, maybe even years to his life. If you have anyone in your family that meets the guidelines, please encourage them to get screened. Do everything that's possible. I know, looking back, if I'd had to get on my knees and beg, I would have begged him to go get screened. Because even what little bit of time it would have given us, it would have been worth it.
Thank you all so much for being with us today. We do appreciate you, and we appreciate all that you do to fight for a world without cancer. Thank you so much. We'll see you next time.